Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. Let's see. I got a interesting case today. A couple of them. There we go. Oh, Greg, you're right. Yeah. Wait, whoever was supposed to be the examinee dipped, and then case 2, the examiner dipped.
I'm always right, Ryan.
Just like my wife, huh?
Mm-hmm.
Interesting. All right. Well, let's do this. Okay. Can you guys see the screen all right? We could do
Yes.
we could do a free for all. I think that's probably the better way to do it. As Greg is right.
Wish I had a buzzer.
All right. So this one's actually interesting. So we have a 9-year-old male, multiple carious teeth. His past medical history includes Down syndrome and obesity. What would you like to know? He's obviously, this is going to be based more on the medicine and anesthesia part.
I can take this one.
Yeah.
Okay. I feel like this one doesn't really require much looking at the screen. Okay. So 9-year-old male, he's Down syndrome, obesity. So I would start out by getting a full medical history on the patient. I would ask specifically for if the patient has any cardiac issues, if they have any history of snoring or any, just because Down syndrome patients typically have a predisposition to OSA.
Yeah.
And then I would ask about specifically like, what do you call it? Like get into the details of what's going on with the teeth. Are they bothering them? Do they have a history of infections?
I understand. So the teeth are bothering him. He's got like 4 teeth that he keeps wiggling out. As per his mother, he just keeps wiggling with them and wiggling them and messing with them. What is Down syndrome?
So Down syndrome is basically it's trisomy 21, so it's a translocation at the 21st chromosome that results in essentially 3 chromosomes of 21. Or yeah.
Sure. So what does it result in facial feature wise and behavior wise?
Yeah, so behaviorally, they tend to have intellectual disabilities and developmental delays. And then in terms of their facial features, they tend to have kind of like a flat faces, class 3 malocclusion or maxillary hyperplasia, prognathism, large tongue. They tend to have, I believe it's hypertelorism, kind of like upward slanting eyes. I'm trying to picture. I have a picture of a Down syndrome patient, but anyway.
The anti-rhomboid slant.
Yeah, that's it. That's the one. And then a flat bridge of the nose.
I'm not laughing at Down syndrome. I'm just laughing at the word that somebody said.
Anyway, yeah.
What would you like to? I'm sorry. What are the different classes of obesity?
I'm gonna have to pass on this one. Pass.
What's the difference between regular obesity and morbid obesity?
Okay. So regular obesity, typically these patients have a BMI of between 30 and 35 versus morbid obesity is anyone with a BMI over 35. BMI is a indicator or a index, I guess, that's dependent on height and weight of the patient.
I understand. So how would you evaluate this patient? He needs 4 teeth out. How would you evaluate this patient for anesthesia?
So I would start first by listening to heart sounds, lung sounds, and then I would essentially kind of do a top-down approach. Look intraorally, look at his Malin-Patty score, look at his
So you get to his Malin-Patty score, and it looks something like this.
Okay. To me, that looks like a class 4, or excuse me, class 3 body.
Sure. What are the differences between pediatric and adult physiology and anatomy as it relates to anesthesia?
Glad her shoes doing a good job.
Yeah. So when it comes to the upper
Clean.
when it comes to the upper airway differences, pediatric patients tend to have smaller noses. They have larger tongues, kind of a floppier epiglottis and larger epiglottis, larger tonsils and adenoids. When it comes to the lower airway, they have more of a funnel-shaped airway rather than a parallel-walled airway, with the cricoid being the narrowest portion. And then they have flatter ribs, more diaphragmatic breathing, poor accessory muscle development.
Very good. Would you do this procedure in the office?
Considering the patient's obesity and his Down syndrome, I would, I don't know exactly how developmentally delayed he is or how cooperative he would be. I would tend to err more on the side of doing this in the OR.
Sure. So you take the patient to the OR for extraction of 4 teeth. And midway through the procedure, everything's going well, but you observe this on his EKG. The machine isn't adequately calculating the heart rate, but this might require somebody else's help besides Albana.
Oh no, I see it. You're good. Good thing about St. Louis is there's no traffic. So to me, this looks like sinus bradycardia.
What's a neat little math trick you can do to calculate the heart rate?
Oh man, I know it has to do about the squares, but I don't know off the top of my head.
Anybody?
It's been a minute. Yeah, that's what I want to know.
Count the boxes, divide 300 by number of boxes, big boxes.
Cool. So assuming the patient has this heart rate, and your calculation is correct, let's say the patient's extremities are also appearing not good cap refill. Cap refill is greater than like 5 seconds.
Okay.
What would you do at this point?
So
The anesthesiologist, it's just a cRNA there. You have basically no help.
okay. I'm assuming patients intubated and all that, like they're under full general anesthesia. Is that correct? I'm halfway through the procedure, you said?
Yeah.
Okay. Gotcha. Yeah, so I mean, typically I would kind of enter the ACLS bradycardia algorithm, and I would give this patient some atropine.
Sure. Assuming he's hypotensive and appearing unstable, would you just limit his treatment to atropine?
I'd give IV fluids as well to resuscitate him. And then probably if he's both bradycardic and hypotensive, I would then not just give atropine, I would give ephedrine instead.
Would you do CPR?
I would, yes.
So you initiate
Yes.
CPR because the patient is a child and they're bradycardic and hypotensive and
yes.
stable. So you keep going. Miraculously, the kid comes to. The operation has already finished with your procedure is already finished without a hitch. The parents are asking now about post-op pain control. Any medications you're going to avoid in a child?
My go-tos for children are typically like ibuprofen and Tylenol. I feel like they do very well with that. And very rarely do pediatric patients require anything stronger like a narcotic. So those would just be my two go-tos.
Which ones would you avoid?
I mean, I would avoid the narcotic post-op.
What about Tylenol 3?
I would also avoid Tylenol 3. I would just do regular Tylenol instead of Tylenol 3.
Sure. So that patient goes. Your next patient of the day is an infant female who has this going on. Your patient's parents want to know, hey, Doc, how common is this?
So cleft lip, typically, I believe it's 1 in 10,000, if I'm not mistaken.
Sure. Is it more common in males or females?
It's typically more common in males, and usually on the left side of the lip, and a unilateral cleft.
Sure. What about an isolated cleft palate?
So isolated cleft palates are typically more common in females, and about 50% of the time, those tend to be associated with some type of syndrome.
Sure. Any populations it's more common in?
So Native Americans are typically the most common, followed by Asian, Caucasian, and then African Americans last.
Sure. The parents want to know, they say, hey, doc, what's the chance of our next baby having a cleft lip?
So the next chance, do the parents also have cleft lips or?
No, they do not.
Okay, so it's 4%.
Sorry, I'm just laughing at the thought of a family of cleft lip people.
You're the worst with anti-myeloid slants.
That's something Zach Jones might get a laugh at too if he was here.
Family of hair lips.
Yes, the hair lip. Yep. So, what's Pierre-Robin sequence?
Sorry, it's a series of, I want to say it's de novo mutations. I don't know the exact genetic background to it right off the top of my head right now. I'm still kind of working on that. But essentially what happens is that these patients tend to have mandibular hypoplasia, large tongues, and I'm blanking. There's 3 characteristics of Pierre-Robin, but anyway.
What's the management like of this current condition when the infant is born?
So typically, depending on the severity of their mandibular hypoplasia and how much they're obstructing, so either
I'm sorry, not Pierre-Robin sequence. That you're dealing with this current patient that we're looking at.
Oh, I'm sorry. I don't see anything on the screen.
Oh.
The cleft lip?
Yeah, the cleft lip.
Okay.
Cleft lip and palate here.
So what's the
showing here?
No, I don't see anything at all.
Let me see.
Maybe that's just me, but you're saying at this there it is. Okay. So when they're infants, right now?
Yeah, this current cleft lip and palate.
Okay. So the first sequence when it comes to cleft lip and palate is to do the lip reconstruction procedure. That typically doesn't happen until the patient is the rule of 10. So you have a hemoglobin of 10. They're 10 weeks old minimum, and they're over 10 pounds.
What about when the infant is immediately born?
When they're immediately born, typically you can do a little bit of lip taping to help out with feeding, and that's really about it. Otherwise, it's just special bottles to help with feeding.
Sure. I'm not going to make you draw out how to repair a cleft lip right now. When is the palate repaired?
The palate is typically repaired between 9 to 15 months.
Sure. What other teams are involved in this patient's treatment?
Yeah, there's quite a few. So there's OMFS, facial plastics, ENT, pediatric, dentistry, orthodontics.
I understand. So how would VPI be evaluated and addressed?
So VPI is something that's typically not evaluated until after if the patient has a cleft palate, but until after the cleft palate is the initial procedure is closed. So typically around, I think 1.5 to 2 years old, when the patients start talking, is typically when they can assess this. And what they typically look for is wall movement when the patients are phonating.
I understand. So when would you perform, let's say the patient is now 5 years old, when would you perform maxillary alveolar cleft grafting?
So typically you want to wait until the canine root is about 2/3 of the way formed, but before it erupts into the alveolar cleft. So usually that's around the age of 8 to 9.
Sure. Anything let's say you're at that stage now. Anything you'd want the orthodontist to do beforehand?
So the main thing I wouldn't want the orthodontist to do is to upright any of the teeth that are adjacent to the cleft, because then that would potentially push the roots into the cleft side where there would be no bone.
Is there anything the orthodontist can do to help you in your grafting procedure?
So they can put brackets on and then just do a little bit of expansion with an RP, rapid palatal expander, just maintain that width.
So you're at that point where you're doing the clefting procedure. Where are you planning on getting bone from?
In these patients, the gold standard is autogenous bone from the hip.
Is there anything unique about the iliac crest in kids?
Yes, if they're less than 12 years old, there's usually a cartilaginous cap on top of the iliac crest.
Sure. What are the goals in your repair of the cleft?
The primary goals for cleft repair are to get bony bridging or bony union between the lesser segment and the greater segment, and then to also have root coverage of any of the adjacent teeth that are in that cleft.
Is there any consideration you're giving to the nasal mucosa?
Oh, yeah, and then sorry, my mom's calling. I'm like trying to do 3 things: drive, answer my mom, and look and think about this case. Sorry, yeah. Also, you want your nasal mucosa. You want to do 2-layer closure of your nasal mucosa. So, so close your nasal mucosa and then put the alveolar bone graft as a sandwich graft in between the nasal mucosa and the oral mucosa, so that you have your 3 layers established at that time.
Since you're already driving and talking to your mom, I'm not going to make you outline your incision and flaps here. Let's keep going and say you're having tension-free. You're having trouble getting tension-free and watertight closure of your cleft. What are some steps you can take at this point?
You can do some like local rotational flaps, like a finger island flap from the palate to try to close things over.
But you're just having, like when you're closing your cleft, you're just having trouble having it closed tension-free and watertight. What would you do?
I don't know. Probably just remove some bone and try to maybe I overpacked it and then try to close it that way.
Sure. Yeah, that's the end of that case.
Okay.
Albana doing that in
Thanks.
the middle of 3 things right there.
Sorry, I just trying to.
That was good.
Yeah. Anyway. All right. Cool. I know I messed up some things, so let's debrief.
Well, that was I think that was a full 12 minutes. We started at 7:36, I think. Almost 20 actually. Anyway, what do we have first? We had a 9-year-old with Down syndrome and obesity. That's right. Let's see. I asked you about the classes of obesity. Well, first of all, you got the Down syndrome question right. It's trisomy 21. They have all the facial features you described, sometimes behavioral or cognitive difficulties, sometimes some prognathism, and a lot of times it's associated with weight gain. BMI for kids is measured slightly different than it is for adults, but in general, BMI is divided into these classes that you can see here. Greater than 40 BMI is considered morbid. Evaluating the patient for anesthesia, you did a good job with that. Like it should just roll off the tongue, which it was with you. You're going through, heart oscillating, heart and lung sounds, past medical, surgical, social allergies, all that. Digging into Mallampati, thyroid mental distance, opening, and looking at their larynx trachea. The difference between pediatric and adult physiology anatomy, that also rolled right off the tongue. That's awesome because that's a dependable little soundbite there.
Sweet.
This slide sort of depicts some of that. Although you may have different words. I know
I gotta sharpen my swords for the oral boards. I learned him from Patel, and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you cake or so.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.